Hey, good morning, everyone, and welcome to the show. I am your host, Vic Sinise, and this is UroNurse, the best place to go for urology healthcare education. If you're watching us live, great. We come to you all those different ways. So, looking forward to seeing a lot of live people those ways. That makes sense. Hey, if you're first time checking us out, be sure to go to our website at uronurse.com, the best place to go to learn more about the show and the best place to watch all of our past episodes. 115. Want to listen to us in your car? No problem. Just go to our Euronurse Plus area. It'll bring you to our podcasting area that you can pick your favorite podcasting format and check us out. Fun way to listen to us in the car. We got a really great show for you today. This is going to be a longer show. It's an hour and a half. So we're not going to be having any Q&A after it. You can put things in the comments if you'd like. Let me know how you like the show. But it's going to be a long one, so strap in. It's really great. We've got three great doctors talking. Dr. Jason Heffron, Dr. Aaron Berger, and Dr. Apit Shah. Both of those two last ones have been on the show before. And it's also going to have this crossfire where they go back and forth on a lot of great stuff. It's a longer show. Like I said, we won't be doing Q&A. I don't have any of my experts on, but I thought this was really good and it was worth the extra time. Hey, the other thing is it's good for 1.5 contact hours. So be sure to go to the website. It'll be up right after the show ends. There'll be a link that'll take you over so you can claim your 1.5 hours worth of credits. So sit back, enjoy, and let's start the show.
Hello, and thank you for joining us today for this Medical Crossfire and Adjunctive testing, charting a new course in prostate cancer risk assessment. This program is brought to you by Physicians Education Resource and is supported by an educational grant from Cleveland Diagnostics. I'm Dr. Jason Heffron, Chief Medical Officer of the Michigan Institute of Urology. I'd like to welcome my colleagues and friends in this program, Dr. Apit Shah.
Hi, my name is Apit Shah. I'm a urologist out of AUS, Associated Urological Specialists in Chicago, a part of Solaris Health, and I'm the director of the APP program there, and I sit on the clinical board of Solaris.
Dr. Berger?
I'm Aaron Berger, urologist, also in the southwest suburbs of Chicago, the Chief Medical Officer, Associate Urological Specialist, and looking forward to the discussion today.
Great. Thanks, Dr. Shah and Dr. Berger. In this program, we will discuss recent advances in prostate cancer screening. We will focus on new biomarker tests that improve diagnostic accuracy and reduce unnecessary biopsies, enhancing risk assessment and decision-making. Today, I want to talk about exploring the benefits and drawbacks of PSA testing. What can we do to improve? PSA has completely transformed how prostate cancer is detected, for making a huge difference for patients. We all know that PSA was introduced in the early 1990s, and following the introduction of PSA testing and screening, we saw a decreased incidence of prostate cancer. However, in 2012, the U.S. Preventive Task Force gave PSA screening a grade D recommendation and recommended against PSA screening. And then they followed that up in 2018 with changed it to a grade B recommendation, which is our current recommendations that allow for PSA screening through a shared decision-making process that we'll discuss in more detail throughout the program. But this Preventive Task Force had a significant impact on how urologists behave. And within 2 years following the U.S. Preventive Task Force recommendation, PSA screening in men aged 50 years or older significantly decreased by an estimated 20 to 39%. And the annual number of biopsies decreased by 21%. So obviously this changed how urologists practice. And what we see is that there was some good and some bad that came out of these changes in behavior. The bad is that if you look at that curve closely, starting when the U.S. Preventive Task Force made that grade D recommendation, we see that prostate cancer incidence has risen by 3% per year. And most of it, unfortunately, is driven by regional stage or advanced disease. And we're seeing advanced disease growing at 4 to 5% per year, clearly having a significant impact on the grade and stage of disease that we're seeing today. But there also was some good. And between 2010 and 2018, the age-adjusted incidence rate of grade group 1 disease halved from 52 to 26 cases per 100,000 men, with the sharpest decline from 52 to 29 per 100,000 men occurring during the years of 2010 and 2014. So we decreased the overdiagnosis of prostate cancer. And also what we saw is that these occurred across all age groups, but were more pronounced in the men aged over 70 years old, with the incidence rates of prostate cancer declining from 189 to 98 cases per 100,000. So we're seeing, the bottom line here is that we're seeing more advanced prostate cancer, which is unfortunate, and we're seeing more metastatic prostate cancer, but also we're seeing less grade group 1 and seeing more appropriate biopsying of the younger men, as well as less biopsying of the older men. So that probably the good that came out of the U.S. Preventive Task Force. When you look at the randomized controlled trials and looking at the benefits of PSA screening, you see somewhat of a mixed result. The PLCO trial, which is a large trial done in the United States, looked at 76,000 men aged 55 to 74. Protocol there was a PSA annually for 6 years, a DRE for 4 years, and a biopsy trigger of greater than or equal to 4 for a PSA. We don't see much impact of PSA screening. However, when you look at the European trial, which was a much larger trial, almost double, 162,000 men, PSA every 4 years, a biopsy trigger of greater than or equal to PSA of 3, we see a 20% reduction in mortality in patients with PSA screening. Similar outcome is for Göteborg. It's another Swedish trial, European trial, a little bit smaller. And then there's another trial that also was a large trial, the CAP trial, which was 420,000 men. They got a single PSA during the study period, biopsy trigger greater than or equal to 3. They saw a 20% reduction. So really, we're seeing in 3 out of the 4 trials an improvement or in mortality when patients are screened. It's roughly about 20%. The U.S. trial, the PLCO trial, definitely had some flaws and maybe can contribute to the reason why we didn't see an impact. We see a high degree of dilution in the screening group. We see contamination in the control group. The control group did get PSAs, and some patients that were supposed to not get PSAs were getting more frequent PSAs. And then there was a low compliance rate with biopsy. So it's hard to really tell the impact of that. But clearly, in the European trials, we're seeing a 20% reduction when patients are screened. We know the PSA is good, but it's not perfect. And I think Dr. Eric Klein, the former chairman at Cleveland Clinic, says it best. And I'll just quote Dr. Klein. Unfortunately, PSA is tissue-specific, but not cancer-specific, leading to overdiagnosis and overtreatment of biologically insignificant cancers, which is widely recognized as a key limitation in its clinical utility. And I think that's what I want to focus on is the weaknesses of PSA, as specifically related to the overdiagnosis, overtreatment of insignificant cancers, and some of the problems associated with PSA testing. We know that PSA cancer is not specific. Elevated PSA can be caused by multiple other factors such as BPH, prostatitis, trauma, transurethral manipulation of Foley catheter, recent procedure, and sexual intercourse. And when you look at a meta-analysis of 18 studies that evaluated PSA, the established specificity and sensitivity of PSA is greater than or equal to 4 to identify prostate cancer are 0.2 and 0.93. So not very specific, but very sensitive. What that leads to in a population series is that up to 3/4, and this is really the problem with PSA, is up to 3/4 of prostate biopsies conducted in the US today yield negative results for the presence of high-grade prostate cancer. Essentially, what further that leads to is overdiagnosis and overtreatment of prostate cancer. If you look at the PLCO and the ERSCP PSA screening trials that I presented on the second slide, we see an overtreatment that's estimated to be 17 to 50% of men diagnosed with prostate cancer. Again, men with insignificant prostate cancers that's not going to kill them, are getting treated. And according to recent estimates, the total number of men aged 50 to 84 overdiagnosed and overtreated is estimated to be between 1.9 and 1.5 million, respectively. So clearly, PSA, if you just use PSA alone, looking at the previous trials, can lead to a significant amount of overdiagnosis and subsequent overtreatment. Not only can it do that, but there's also a psychological impact when you look at it at the patient level. And there's two types of anxiety that we typically see with patients related to PSA. We see that the overall levels of anxiety, here's a recent publication that looked at this specifically from Journal of Clinical Oncology, JCO, and we see that the overall levels of anxiety were low across all time points, except at the 30-day assessment of men who received a cancer diagnosis. This seems somewhat obvious. If they have a cancer diagnosis, it's going to have a bigger psychological impact. But also the study showed, which I found interesting, is that post-biopsy symptoms or complications are linked with raised anxiety, which is distinct from the anxiety related to the cancer. So when patients do have complications or do go through the recovery period associated with a biopsy, there is significant amount of anxiety that the patients do report. After recovery from the short-term impact of biopsy symptoms, anxiety remained higher in those with the cancer diagnosis. So I think it's important, the point of this study, and it's important that why I'm discussing it today, is imperative that patients and doctors fully consider the physical as well as psychological potential risks associated with the prostate biopsy before commencing the diagnostic process with PSA testing. Also, we know that biopsy is a procedure, it's an invasive procedure, and there's complications. If you review the published literature, the most frequent complications, fortunately, are minor and self-limiting, but those are usually hematuria and hematospermia. Almost 25% of the patients do experience lower urinary tract symptoms, but only a few have urinary retention, and we see higher rates of urinary retention with the transperineal approach. We do see temporary erectile dysfunction. The etiology is not clear, but again, it's usually temporary and can go away in 1 to 6 months. The incidence of infectious complications are higher in patients with higher comorbidities. And if you look at the SEER data, about 6.9% of these patients are admitted after a biopsy. So a biopsy is not a simple, benign procedure. There are definitely complications associated with that. That being said, as much as I talk poorly about PSA, PSA still is a good test and remains the single most useful tool we have today for the early detection of prostate cancer. Current approaches recognize PSA testing as a powerful stratification tool for obtaining a baseline in healthy men. PSA testing is inexpensive, non-invasive, and has been proven effective in reducing prostate cancer mortality. It should not be dismissed. It should serve as an essential first step in the assessment of a well-informed man about the prostate cancer risk. So when you look at current options for evaluation of patients with an elevated PSA, we see 4 kind of treatment paths. You can do a traditional treatment path, which is PSA only. What we're going to focus on a lot today is PSA with an ancillary test, PSA with prostate MRI, or even consider an MRI plus an ancillary test, because the goal here is to increase the specificity, improve the sensitivity, and eliminate overdiagnosis of non-lethal prostate cancer. And this is what we see in the guidelines. Here's the AUA guidelines, and that PSA should be the baseline screening test. PSA should be repeated. We'd never go off of one PSA. We check it twice. Screening should start at age 45 to 50. What I really want to highlight here is that after shared decision-making with an elevated PSA or an abnormal PSA, patients should consider an adjuvant biomarker or prostate MRI. This is within the AUA guidelines. And we see the similar thing in the NCCN guidelines. Always repeat a PSA. DRE should be strongly considered. And then patients should be considered for a multi-parametric MRI, and then consider biomarkers, which in the next module we'll talk about. Dr. Berger will go through an extensive discussion about the biomarkers that should be considered to improve the specificity of an elevated PSA. So thank you. Considering the wide range of factors that can influence PSA levels, such as BPH, prostatitis, all the stuff that we deal with on a day-to-day basis, how can urologists better stratify patients of the risk and avoid overdiagnosis and unnecessary biopsies? Aaron, what do you think?
Yeah, I mean, we're going to discuss in Module 2 all the new technology and new biomarkers that are available that really were not available when some of the trials you discussed came out. I mean, certainly the data you presented and the task force recommendation to go to a category D was probably misguided, especially with some of the poorly designed trials like PLCO that they were reviewing, where the comparator arm was kind of standard of care, which could have included PSA testing, which is not a very good control arm. But I think the one benefit of having it become a poor recommendation and then now kind of swinging back the other way is that we are minimizing overtreatment and overdiagnosis of really clinically insignificant disease, which should be the goal. Just find the ones that need to be treated and not the ones that we can just ignore or not even do a biopsy in the first place. So we'll certainly discuss some of the new technology and the rest of the presentation here, but I think all of our goals should not to just rush to do a biopsy with just one PSA. That's clearly in the guidelines. I think there's probably still, some practitioners that see a new consult with one high PSA and say, okay, and do a biopsy with no other testing. And that's certainly in 2024 is really not the right answer. You should do some additional testing and find out, do they really need to have a biopsy in the first place?
No, those are great comments. RP, do you agree with that? I mean, can you still in this day and age biopsy a patient on PSA only?
Not off of just one PSA. Certainly, at least getting a repeat PSA is the bare minimum, and really utilizing the new biomarkers out there is becoming more and more common up front before going to biopsy. I think the last decade, we've really been humbled by what we've learned, and urologists are definitely more aware of the potential complications and how high those rates of complications are with biopsy. So we're trying to utilize every test available to make sure that when we are deciding on a biopsy, that we're trying to give ourselves and the patient as much information as possible so we can go through that shared decision-making process together. The other thing to consider when we talk about risk assessment is, there's still a lot of risk assessment tools out there and algorithms that we can use that bring in not only PSA, but if you have prostate volume, PSA density, or family history, or other variables, and there are so many variables that go into this, but all of those other variables that we should think of, there are good risk assessment tools that kind of put that together for us.
You brought up you mentioned something I think that's very important, is the shared decision-making process. Obviously, elevated PSA, the management of elevated PSA diagnosis is much more complicated and has changed over the last decade, which we'll get into. But how do you approach the patient? How do you, address the anxiety associated with that? And what's your strategy, when talking to a patient so that you do share decision-making? What does that really mean to you? And what does that mean in an everyday practitioner's clinic?
Yeah, I think that.
Go ahead, please.
Sorry, I think that's a very complex discussion to have. But starting out with some simple statements for patients to understand what is going on. So first of all, telling patients that just because you have a high PSA does not mean you have prostate cancer is a really important thing to highlight over and over again during that conversation, so it really sticks with them. You have to tell them that we're going to go down a path of discussion, and I'm going to give you a variety of options, and we're going to make a decision together. And just laying out that groundwork right from the beginning is really important. It settles the patient down. It allows them to pay attention to what you're saying. And then when you go through the different tests that are available or risk assessment tools or whatever it might be, you can explain those better to them and then arrive at a decision together in terms of what the next step should be.
Yeah, I think arriving at a decision together is definitely the key, and helping them as essentially we're like teachers. We teach them the good and bad, and let them make the decision ultimately. Aaron, anything differently you do with your patients or any?
No, I think those are all good comments. I think the one point on shared decision making is that if you look at the guidelines in terms of who should be screened for PSA and the whole process of shared decision making, a lot of those guidelines are really also geared toward primary care physicians, which I think is so unrealistic. I mean, it's hard enough for us as urologists who are very knowledgeable in this space to have a in-depth discussion, but when you're kind of in the guidelines telling primary care doctors, well, if you're going to offer a PSA to someone for prostate cancer screening, you should have shared decision making about if a biopsy is necessary, all the pros and cons of doing screening in the first place. When they're treating diabetes, high blood pressure, cholesterol, 10 other things in their 10 to 15 minute window that they have to squeeze a bunch of patients into, there's no way that's going to happen. So I think really the message for primary care doctors should just be that PSA testing is important, and if it's elevated, then we'll work on the shared decision making and find out, based on all these other nomograms and other tests we have available, to find out if a biopsy is even needed. But it's just not realistic to expect primary care doctors, with all the other tasks they have to do and documentation, that there's been any true shared decision making going on. It's just not possible.
Yeah, and I think that's why our Pete's comment's so spot on, is that the first statement, when, if you just put yourself in the patient's shoes, that the primary care drew a PSA, they tell that the patient, your PSA is abnormal, you got to go see a urologist. Like, human nature is to assume that you have cancer. And I think, when that patient first walks in the door, is most of the time, statistically, we know the performance of PSA is not perfect. And we know statistically, assuming it's below 10, that they don't have cancer. And I think telling them statistically, probably you don't have cancer, I'm going to do some additional testing to see if you do, I think is really critical, because, they come in anxious, they come in worried, they're nervous. And if you can just lower that level of concern right off the bat, I think you can have that shared decision-making conversation. You can run through the options of a biomarker adjuvant testing, and really get to, what's your true risk of having a clinically significant prostate cancer. So when you do talk to a patient about a biopsy, any strategies, or, how do you relieve that anxiety? Or, I saw that we just mentioned the anxiety associated with the biopsy, and its long-term effects, both psychologically and potentially physically. How do you counsel those patients?
Well, I start, if we've reached the point where we think a biopsy is the right decision between the provider and the patient, then you're absolutely right. It's the provider's job to make sure the patient's not only informed of all the things that can happen with a biopsy, but also to calm them enough to make sure that they come and actually complete the biopsy. So explaining to them just that it is a very common procedure that urologists do, that we do this routinely, that we have strict protocols in place in terms of antibiotics and preventing complications, can kind of get them a little bit more ease in terms of proceeding with the biopsy.
Yeah, so clearly a biopsy we show is invasive, psychological. What are the economic and healthcare system burdens of unnecessary prostate biopsies?
Yeah, I mean, certainly doing any unnecessary procedures is something we should all be avoiding. And, some of the tests that we're going to be talking about later on, it's not this, these tests have costs as well to the system. But certainly doing a blood test or urine test, which is basically, non-invasive other than drawing blood or urinating in a cup, is not going to cause any significant harm to the patient. And certainly biopsies these days, we have good antibiotic prophylaxis. Certainly people still do have episodes of infection, sepsis occasionally, very rarely, but it happens. And if those patients need to be hospitalized, that certainly is a significant cost, not only to the patient, but to the healthcare system. So we want to avoid as many invasive procedures as we possibly can. But I think with some of the tools we have available, not only the traditional tools, nomograms, certainly doing a DRE to make sure there's no hard nodules, anything like that, along with some of the newer testing we're going to discuss, as well as imaging with MRI, I think we can be much better prepared than we were several years ago to really have that shared decision-making process with the patient to say, do you really need to have a biopsy or not? Or is this something we can just say, hey, you know what, your adjunctive testing is kind of equivocal. We'll just check your labs again or your exam again in 6 months, or something along those lines, and just follow them and just hold off on the biopsy. And as long as they're comfortable with that, I think most people would prefer to not do a biopsy if they don't need to.
Yeah, I think that's the key, is that, a biopsy is not a benign procedure. It is associated with significant psychological impact on the patient, especially if they have any adverse events, even minor ones. It does contribute to their anxiety. And I think what we see from the guidelines, the AUA, as well as the NCCN, is that after a repeat PSA, I think we're moving towards a world of urology where PSA alone, or even a repeat PSA alone, is no longer adequate in the primary biopsy setting. And that when we review and look at all these adjuvant markers, that we can potentially reduce overdiagnosis, diagnose only clinically significant disease. We know that we don't want to, diagnose Gleason 6 and place a patient on active surveillance. Overtreatment, we've seen a lot of space, but essentially what we want to do is diagnose patients that need to be diagnosed, that have significant risk. And what we see now is that a lot of these adjuvant biomarkers give us that data, give us that information so that we can, apply shared decision making and let our patients better understand what are the potential or the likelihood of finding clinically significant prostate cancer. So we're going to switch to module 2 now, where Dr. Berger is going to walk us through the data on all of these adjuvant biomarkers, how they perform, and how they should be applied.
All right, so in module 2, we are going to do a review of adjunctive tests for prostate cancer risk assessment and review some of the characteristics of these tests along with the clinical evidence. Again, I'm Aaron Berger, Chief Medical Officer and Director of Clinical Research at Associated Urological Specialists in the southwest suburbs of Chicago. So as Dr. Hafron alluded to earlier and showed the NCCN guidelines, if a patient is presenting for an elevated PSA and they've only just had the one PSA test, first of all, the next thing we should be doing is a repeat PSA, along with doing a digital rectal exam if this was not initially performed, and certainly do a workup for benign disease. As we discussed previously, PSA can be elevated for other benign diseases such as prostatitis, enlargement of the prostate, or other issues like an infection. So certainly you want to do a workup to exclude those things as an option. Moving forward, though, if the repeat PSA is confirmed elevated, you can certainly move on to additional testing, including doing a multiparametric MRI and some of the new biomarkers that we're going to be focusing on specifically in this section of the presentation. So this is just a little blow up of the current NCCN guidelines. And although there are several other biomarkers that are commercially available, the ones we're going to be focusing on here today are going to be the ones that are actually currently in the NCCN guidelines. And this is going to be including the Prostate Health Index, or PHI, Select MDX, the 4K score, the ExoDX prostate test, the My Prostate Score, or MPS, and ISO-PSA. Again, this is not an extensive list because there are other products available, but these have yet to make it into the NCCN guidelines. So we're just going to be focusing on these 6 tests today. So the Prostate Health Index, or PHI, is basically a calculation that is done using total PSA, free PSA, and this P2 PSA isoform, and does a calculation, which you can see there, that basically comes up with a score that is then used to risk stratify patients. So this is initial validation studies. There were multiple multinational studies showing that the prostate health index outperforms all three of the components on their own. So basically, the combination of using this formula is better than the total PSA by itself, the free PSA by itself, or this isoform of the pro PSA or P2 PSA by themselves. So it is approved for patients with a total PSA between 4 and 10 and having prostate exam findings that are not suspicious. So in a meta-analysis from 2022 that reviewed 60 studies and over 14,000 patients, the pooled sensitivity and specificity for prostate cancer detection was 0.791 and 0.625 respectively. And the pooled sensitivity and specificity for clinically significant prostate cancer was 0.874 and 0.569 respectively. Again, all of these are better than the individual components of the PHI alone. So it definitely has utility, and it's been widely used and widely studied. Again, this is a review of over 14,000 patients. Moving on to Select MDX. So Select MDX, unlike the PHI, which is a blood-based test, this is a urine-based test. So this is a urine-based biomarker that measures 2 mRNA cancer-related biomarkers, which is HOXD6 and DLX1. This is a urine sample collected after a DRE is performed. So basically, this is something that needs to be done in the office because it does require a DRE. And the recommendation is to perform a fairly vigorous exam. And what you're trying to do is basically get the prostate to express any significant markers that may be present. So after the exam, the patient has a urine sample performed, and the biomarkers are then tested, and then this is combined along with clinical risk factors such as age, PSA, DRE findings, and prostate volume to come up with a Select MDX score. So this is a binary test, so it basically is going to come back kind of a positive or negative. So basically, this is just a sample report of how it would look. So if you have this in this particular sample, so the patient had a very low risk. So this basically is saying the patient has a very low risk for the detection of grade group 2 or higher, or Gleason 7 or higher prostate cancer. And then if you look at the right side of the screen here, again, this is showing a positive test where you're seeing 39% likelihood of prostate cancer upon biopsy and almost a 20% chance of having clinically significant cancer. So it is a binary test, and it'll kind of tell you if this is a patient that should have a biopsy, or at least one factor going into your discussion with the patient if they should have a biopsy based on urine rather than blood. In the validation study, this had just under 2,000 men undergoing prostate biopsy, of which 715 had a PSA less than 10. The area under the curve with this was 0.82 and had a negative predictive value of 95%. So this was superior to the prostate cancer prevention trial nomogram in this population. This was the comparator here, was using the PCPT nomogram. And the meta-analysis recently reviewed 14 studies. This was from 2019. So 14 studies with just under 2,600 patients. And the pooled sensitivity for clinically significant prostate cancer was about 81% and the specificity of 52%. So if you remember the PHI data, this is actually very similar numbers to the prostate health index. But again, this is a urine-based test versus the blood-based test. So moving on to another blood-based biomarker, this is the 4K score. So 4K score is a blood test that measures 4 prostate cancer markers, including the total PSA, free PSA, intact PSA, and human kallikrein 2, or HK2. This is intended for men 45 years or older with an elevated PSA and or an abnormal prostate exam. And a higher 4K score correlates to a higher risk of clinically significant prostate cancer. This is just a sample report of what a 4K score looks like. So you can see here, this is a 4K score of 15.6. So this now shows that they are intermediate risk. for having clinically significant prostate cancer. And this test also does repeat a total PSA. So if you see a patient who comes in with an elevated PSA and you say, yeah, we should do a repeat PSA, but we also want to consider a biomarker, this is a test you can use because it does give you a total PSA result along with this 4K score, so you can get both. And then if you look down at the bottom of the page, you'll see that a 4K score of 15.6 basically puts them in this risk category where all subjects have just under a 20% risk of clinically significant cancer. And if they are African American, then their risk jumps up to around 26%. So it also does stratify for patients based on all comers versus African American, which is an important distinction there as well, since certainly African American patients do have a higher risk of more high grade and more aggressive disease. So in this multinational trial, which was from 2015, this was the initial validation study that showed an area under the curve of 0.82 and a net benefit, again, compared to the prostate cancer prevention trial risk calculator. So similar comparator as the previous SELECT-MDX. And they concluded in this study that there would be a possible reduction of between 30 to 58% biopsies if the 4K score was utilized. 4K testing applied to a large population study of unscreened men between 1991 and 96 indicated the long-term risk of prostate cancer mortality with a 4K score of less than 7.5 was only 1.7%. So again, we're trying to eliminate and not do biopsies on patients who have a low risk of clinically significant disease or certainly lethal disease. And this does indicate, and this is from the early 90s. So this is a fairly old test or fairly old cohort of patients that the long-term risk with a low 4K score is very minimal. The 4K score greater than 7.5, there was a 13% risk of prostate cancer death at 15 years. So again, looking here, you want to be discussing potential biopsy and other testing for these patients, given the fact that their risk jumps up to 13% with a score above 7.5. So moving on to another urine-based test. So this is the ExoDX prostate test, or the full name is the Exosome DX Prostate IntelliScore, or EPI. This is a urine-based test for men 50 or older with a PSA between 2 and 10. This is a first catch urine without a DRE. So unlike the SELECT-MDX where you're required to do a DRE prior, this one does not require a DRE, but they do need to have the urine in their bladder for at least an hour. So as far as utilizing this test, a lot of patients, when they come into a urologist office and see us, they may give a urine sample when they first come in. This is not going to work necessarily if you're doing this, if you want to do this test, because they have to have the urine in the bladder for at least an hour since their last void. So that is something, as far as workflow, you need to be conscious of. And this basically looks at exosomal RNA extracted from the sample, and 3 markers checked are ERG3, PCA3, and SPDEF. So these are 3 prostate cancer associated markers. And in the validation study evaluating the risk of clinically significant prostate cancer with a cut point of 15.6, there was a 91% sensitivity and a 92% negative predictive value. And then a clinical utility study using a blinded control arm, that 68% of urologists indicated that ExoDX influenced their decision to recommend or defer biopsy. And 30% more high-grade prostate cancers were found with positive ExoDX than in the control arm. And in a meta-analysis reviewed, this is from 2022, reviewed 2 prospective studies and a control arm of clinical utility studies, so about 1,200 patients total, with an AUC for ExoDX was 0.7, which exceeded total PSA and, again, the prostate cancer prevention trial. And a cut point of 15.6 would avoid 23% of all prostate biopsies and 30% of unnecessary biopsies, showing only grade group 1 disease. So again, this is a binary test. You're either above this cut point or you're below this cut point. But certainly the higher you are, it is a little bit more concerning. You can see kind of the reporting here. So this cut point is 15.6. So if you're below the cut point, there's a low risk of high-grade cancer, or if you're above, there's a higher risk of high-grade cancer. So again, this is a non-DRE first catch urine sample. They extract the exosomal RNA, and then come up with this ExoDx score. And again, this is for patients with PSA levels between 2 and 10 who are 50 years of age or older. And the final urine test we'll be discussing here is the My Prostate Score, or MPS. This is now in its second version, so the MPS 2 came out relatively recently. Again, this is a post-DRE urine sample based test, and this is for patients with a PSA between 3 and 10. The original My Prostate Score test was a 2-gene panel, but the updated version now has an 18-gene gene panel, which are listed here. I won't go through all of them, but you can read the list here. But so now it's an 18 biomarker panel versus a 2 on their initial test. So this was studied in biopsy-naive men, as well as in men with prior negative biopsy. And they indicated about up to 95% negative predictive value in biopsy-naive men and up to 99% negative predictive value for men with a prior negative biopsy if the My Prostate Score was coming out as low risk. And the cutoff for low risk is dependent on prior biopsy history and whether the MPS was run as a biomarker only or in combination with other clinical factors. And the validation study for the second generation, or MPS 2, the AUC for the original MPS was 0.71, and with the new version, it was 0.81. So with these additional genes that they're now checking, they did get a higher area under the curve for their test. So the MPS 2 could reduce unnecessary biopsies in their studies, showing about 35 to 42% reduction in biopsies in the initial biopsy population, and a 46 to 51% reduction in the prior negative biopsy population. And the MPS 2 outperformed PSA, the prostate cancer prevention trial risk calculator, and PHI in this particular study, which was from JAMA just earlier this year. And the final test we'll talk about is another blood test. So ISO-PSA. This is a blood-based test for patients who are 50 years of age or older with a PSA between 4 and 25. Prostate cancer cells make structurally modified PSA proteins. So this test uses a separating solution in a centrifuge tube that separates out the normal versus the modified PSA proteins from cancer cells. And it can be utilized regardless of biopsy status, whether they've had a biopsy previously or not. And it can also be used regardless of if they're taking a 5-alpha reductase inhibitor for enlargement of their prostate and urinary symptoms. So this is just kind of the picture of what this looks like. So the blood goes into the special centrifuge tube. It gets spun down, and then it separates out the structurally altered PSA, which is created by cancer cells, versus normal PSA. And then it comes out with this report. And again, similar to the 4K score, this does do a repeat total PSA as well. So basically, this patient in particular had a total PSA 3.1, and their ISO-PSA index, which is the score we're looking for here, came back less than 6. So that has a very high negative predictive value here of 90% that this patient does not have clinically significant prostate cancer. And this is just a little bit of a blow up of what the reporting looks like. So if the ISO-PSA index is less than or equal to 6, there's a decreased risk of harboring high-grade cancer. If it's greater than 10, there's an increased risk of having high-grade cancer. And if it's between 6 and 10, they indicate clinical decisions should be based primarily on baseline risk characteristics, such as age, family history, race, ethnicity, and prostate MRI findings. In the validation study of 888 men scheduled for prostate biopsy, the AUC was 0.78, which was better than total PSA and better than percent-free PSA, had a negative predictive value of 89% using a cutoff of an ISO-PSA greater than 6, and the results were similar in biopsy-naive and prior negative biopsy groups. The ISO-PSA study, in conjunction with multi-parametric MRI, ISO-PS index of less than or equal to 6, and a PIRADS 1 to 3 MRI finding only had a 4.5% chance of significant prostate cancer, whereas if you had a PIRADS 3 with an ISO-PSA index of greater than 6, there was a 16% chance of significant cancer. So with that, that's the summary of the different NCCN-approved biomarkers that are available. So now we'll go through some discussion of how these can be utilized in your clinical practice. Thank you. So now that we've seen some of the different biomarkers that are clinically available and in the NCCN guidelines, What do you think are some of the key attributes and limitations among the available tests? Dr. Hafron, why don't we start with you?
Yeah, Aaron, that was a phenomenal summary. Really packed in a lot of information. Great points there. I think what you look at, there's little nuances to each of these. I think overall they perform very well. They have increased sensitivity. They have increased negative predictive value. They perform better than a standard PSA. What you mentioned in your talk at some point, I think is really critical. How do you incorporate that into the workflow of a very busy clinic? And the way that I look at it is, of these 6 markers that are in the NCCN guidelines, 3 are blood-based and 3 are urine. And I think that the urine-based markers have some difficulty for me in my clinic, especially, SelectDx and MPS 2.0 are my prostate score, because they require a DRE, then the patient has to go urinate. So in my workflow, it can slow me down. So I tend to stick to the blood-based markers, and I think those are very helpful because you can just order the blood test. It won't really slow you down. I think ISO-PSA is a wide open test. You can use it for PSAs 4 to 25. It doesn't matter if they're on ARI, and it's pretty well validated and simple. I guess my point is they all perform well, and what we encourage our partners to do is use these with the elevated PSA, but use the one that makes the most sense to you. Use the one that works in your clinic and can maintain your efficiency and won't slow you down. I like ISO because of, it's 4 to 25. I'll use occasionally a 4K score if their PSA is below 4, because it's validated. In younger men with a PSA below 4, you can go down there. But that's what works for me. I don't know. Pete, what do you think? What do you think is key?
Yeah, I mean, I would echo what you said exactly. I think there are pros and cons to all of these tests, and you have to find the one that will work the best in your clinic flow. You don't want your clinic to slow down or your ability to order these tests to change depending on how it's done. So, we also tend to do ISO-PSA the most within our clinics, and for the reasons just like you stated. So one is I don't have to worry if they're on a 5-alpha reductase inhibitor. 2, the PSA range is wider, between 4 and 25. And then number 3, which I think is a really important point, is you're automatically getting a repeat total PSA. And so it's not an additional, if somebody just comes in with an elevated PSA, you might say, well, I have to follow some guidelines and at least get a repeat PSA before considering a biomarker or at the time of considering a biomarker. And sometimes if you're doing a urine test, then are you still going to get a blood test to repeat a total PSA at that point, which doesn't really make sense. So we tend to utilize ISO-PSA quite a bit, and it just works really well with our clinic flow.
And there's certainly, as we talked about, multiple options. And I think in some patients, if you do a blood-based test, which there's good options, as we just discussed, and it's a somewhat borderline, and you have a patient who's really hesitant to move forward with biopsy, or potentially can't get imaging for some reason, or doesn't want to get an MRI, certainly the urine tests are another option. I mean, certainly we don't want to order a bunch of tests for no reason, but if that is something that will help us to get a patient who's hesitant, over the finish line and say, hey, you have a blood test and a urine test that are both suspicious or moderately suspicious, that's something we need to consider. So along those lines, Pete, how do you think, because, some would argue that these tests have cost, certainly cost is something we need to discuss with patients, especially if they're younger than Medicare age. If they do have Medicare, most of these things are covered pretty well, but if they're under Medicare age, they may have, some out-of-pocket costs. So how do you discuss, the value of these adjunctive tests with patients and that it's beneficial to potentially avoiding a biopsy?
Well, I think you start by just talking about the biopsy. I think if you most patients want to avoid a biopsy if possible, or they at least want to have as much information going into a biopsy. And so you have to explain that there might be a cost involved, but every step of the process could have a cost involved, and the cost of a biopsy is certainly high as well. And the psychological cost that Jason spent a lot of time talking about is also high. So, with everything that we do, it's important to realize that there's a cost and to explain that to a patient.
Yeah, I agree too. And I think the other thing is why I like to use these adjuvant tests is, you really can avoid a lot of unnecessary biopsies. I mean, Aaron, you touched out on in your presentation is that, you really see about 30 to 55% reduction in biopsy when patients get a biomarker prior to a biopsy. So we are addressing that overdiagnosis. To our Pete's point, no one wants a biopsy, or they want to make sure the doctor's absolutely sure you need a biopsy. So if you tell a patient, I want to do an extra blood test, yeah, I mean, everything costs money, but this will confirm whether you really need a biopsy. I rarely have patients say no. And I honestly, this is, I don't have numbers here, but it's rarely not covered by insurance. Because if you look at it from a health economic standpoint, and most of these biomarkers, when they've done these studies, they reduce the biopsy rate, by 30 to 50%. ISO-PSA was like 55% reduction in biopsy. So as a payer, there's no reason why they wouldn't want us to use these, even though they cost money, but they're cheaper than a biopsy. They're cheaper than an MRI, and we know they're significantly cheaper than an episode of sepsis requiring a hospitalization.
And Aaron, you make a really good point that sometimes, you'd like to utilize the one that you think is most appropriate for the patient in terms of biomarkers, but sometimes you need more information, or the patient needs more information before making the decision on whether to do a biopsy. So it's really interesting, and there's some data that you presented for ISO-PSA of its utilization of using the biomarker and utilizing an MRI together to really hone in on the risk of significant prostate cancer. And so it's not necessarily a this or that question. It sometimes is a this and that.
Yeah, and certainly the points about the workflow is certainly very important. We're all busy, and it's hard to kind of stratify who you're seeing for what. But there are certainly strategies. I know when some of the urine tests first came out, I would just tell my staff, if you see a new patient coming for elevated PSA, let's not check that routine urinalysis that we normally do for most new patients. Just mark it, don't check it, because we may need to do one of these urine-based biomarkers. And certainly the exosome test does offer a home testing kit, so it doesn't require a DRE. So that's another option that, if they do miss out in the office, you can always set that up later. But certainly a blood test, I think most of our offices, we can always do blood tests, especially if the patient's not had a repeat PSA. I think the point you made about having that total PSA repeated as part of a couple of these blood tests is certainly great. So as far as do you have a defined care map, Jason, in your practice, for managing these patients with a new consult for elevated PSA? Do you have a pretty set pathway you follow?
Yeah, I mean, yes, and I think it goes back to the pathways that we were all a part of for Solaris Health, is that we break them down into no previous biopsy versus a history of a prior negative biopsy. So if I have a patient with no previous biopsy, elevated PSA, we're going to get a history, physical DRE, assess family history, any high risk features or any concerns mostly related to family history for homologous recombinant mutations, breast cancer, ovarian, et cetera, prostate. But then I pretty much will always order a biomarker, and I'll pretty much always order an MRI. If there's a payer issue, I will start with a biomarker, and then if the biomarker is positive, I would transition to an MRI, because again, if I can get a negative biomarker, a negative test, the NPVs on most of these are greater than 90%. So if you get a 90% NPV, a negative test, that's great. And that's, it lowers my anxiety. Patients are really comfortable. And I can say, you know what? We can just follow your PSA. We don't have to do a biopsy, and we don't have to do an MRI. But if I have high suspicion or there's significant risk factors, I will just do both of them up front. Kind of what you highlighted is I like to have all that information in front of me when the patient comes back to decide if this is something or nothing. And, you quoted the Bednar paper from ISO-PSA. When you combine ISO-PSA plus an MRI, and they have a less than 6 index, ISO-PSA index, and a PIRADS less than 3 lesion, their risk of prostate cancer is less than 5%. If they have a 3 or 4, a 3, it goes up to 16%. I think the point here is that when you're sitting down with a patient to really decide whether they need a biopsy, you can really, with these biomarkers plus or minus the MRI, get really predictive and give them really hard numbers to help them make the decision of whether they need to be evaluated, whether this is something or nothing.
Yeah, those great points. I think the role of MRI is certainly something that's been studied or being studied with some of these other biomarkers and really improving their risk stratification and adding MRI. So, Arpit, as MRI, are you doing that for pretty much all your biopsies or recommending it for all your biopsy patients who you think need a biopsy?
Yeah, and I follow a similar algorithm. If I feel like the patient going with an elevated PSA, an abnormal biomarker, let's say, if I have a higher risk of patient having prostate cancer, then I will get both the biomarker and the MRI up front. If not, then I'll at least get the biomarker, especially if there's a payer issue, and then still talk to the patient and encourage the patient of the benefits of an MRI. I think just in terms of biopsy technique, it does make an impact. And we're going to talk about this in the next section. When you talk about post-biopsy patients, it's just you almost have to do it in terms of a biomarker and an MRI.
Yeah, but I think a good point too is, we practice in communities, we work with a large healthcare system, is that the quality of the MRI, we look at these publications at these centers of excellence with great results. And I know because I work with music and we see the performance of MRI in the community, and it's not equal to the publication. So I think MRI is great. Obviously, it's important in the evaluation, but something that as a community urologist working in multiple health systems, or you may not have exposure to a MRI prostate expert, is that the quality can be variable. And I think that as a urologist, you have to understand the quality, the experience, and work with your radiologist to understand, the reads, work with them and communicate with them, because prostate MRI is not easy to read. It's not like a chest X-ray or a CT of the abdomen. There is a skill to it, and there's a learning curve with it. And I think biomarkers in the community make more sense because that you level set the quality of your evaluation. You're not relying on the skill set of your radiologist that can be anywhere on the in the journey, or anywhere. So biomarkers, I think, are great in the communities, especially if you don't have access to a high level, dedicated prostate MRI expert.
Yeah, I think that's a great point. We don't want to put, I personally do most of my biopsies or pre-biopsy get MRIs, but there's certainly a lot of, depending on your location, can be some false negatives, as you just said. So if you have someone who has a, quote unquote negative MRI or no suspicious lesions for prostate cancer, and they have a very high like ISO-PSA index, that's a patient that should get a biopsy, because we don't want to miss those kind of MRI silent high-grade cancers, which we definitely have seen. So last topic here is how are you utilizing some of these biomarkers? Jason, we'll start with you, for patients on active surveillance who we're following for their prostate cancer.
Well, most of these elevated PSA biomarkers aren't really well validated in active surveillance. So I don't honestly use them. I don't think, I think there's been work and we need a biomarker for active surveillance. There's been some preliminary work to see if these are predictive, but there's been, in my opinion, no well validated. I stick to PSA, MRI, and biopsy to manage these patients.
Yeah, I would agree with that. I currently do not use any of the biomarker tests for my active surveillance patients. I rely on PSA kinetics and MRI to really guide decision making. I think that's why we have robust active surveillance protocols. We don't know what's going to happen to these patients necessarily, and most of these patients are getting a repeat biopsy within 2 years of initial diagnosis. It will be great when we have some validation from these biomarkers or alternative biomarkers in the active surveillance population. It's a pleasure today to be talking to you all about prostate cancer screening in the post-biopsy setting. My goal is to integrate guidelines and evidence to improve our clinical decision-making. I'm Arpit Shah, urologist at Associated Urological Specialist, part of Solaris Health in Chicago. The AUA and NCCN guidelines do provide a template to aid us in the decision-making process of how to screen for prostate cancer after a patient has had a negative biopsy. And we're going to go through those guidelines and explore them further. And after reviewing them, we can have a more thorough discussion of the nuances of this topic. So what do we do with our patients who've undergone biopsy, which was negative for prostate cancer? And what are the next steps in terms of screening? Well, the first guideline statement that the AUA makes is that clinicians should communicate with patients following biopsy to review the biopsy results, reassess risks of undetected or future development of Gleason grade 2 or above disease, and mutually decide whether to discontinue screening, continue screening, or perform adjunctive testing for early risk assessment. And so it sounds pretty obvious, but the first thing we got to start with is reviewing the results of the biopsy with the patient. And that's obviously the first thing that needs to get done. And with prostate cancer, we know that the results can be more nuanced than just benign or malignant. We have these diagnoses of high-grade PIN and ASAP in patients, which can somewhat change the risk of detecting prostate cancer in the future. And we need to be able to communicate what those findings mean to a patient. So starting with high-grade PIN, which stands for high-grade prostatic intraepithelial neoplasia. And what it is it refers to changes in the cell linings, the prostate glands. And why does it matter? Well, it's not cancer, but it's a warning sign. We know men with high-grade PIN are at a higher risk of developing prostate cancer in the future. And you should kind of consider it as a check engine flag. Make sure that you monitor the situation closely. Moving on to ASAP, which stands for atypical small acinar proliferation. What is it? Well, it's a finding where some of the prostate cells look suspicious, but not suspicious enough to be diagnosed as cancer. And it's really considered a gray area. It's not normal, but it doesn't meet the criteria of cancer. And because of its uncertainty, doctors often recommend further testing in patients with ASAP to get a clearer picture. So after talking about the results, the second thing that needs to get done is reassess the risk of undetected or future detection of significant prostate cancer. And this is based on a variety of variables that I wrote in the slide. So including age, race, we can use total and free PSA, PSA density, because we usually have a prostate volume at this point, DRE findings, presence of germline mutations, what the pathology was on prior biopsies, such as ASAP or high-grade PIN, the results of adjunctive testing, the different techniques of that were utilized for the first biopsy, the planned techniques of the second biopsy or subsequent biopsy, the MRI findings, and then family history. Finally, we need to decide using shared decision-making whether we should continue future screening, stop screening altogether, or perform further tests. The next guideline statements is that clinicians should not discontinue prostate cancer screening based solely on a negative biopsy. So once again, we know that what a negative biopsy is, but we need to communicate what that is with our patients. We know that there's no cancer detected, but there still could be cancer there. We need to review the concept of sampling error to our patients and make sure that patients understand that a negative biopsy may still have undetected prostate cancer or a risk of developing new cancers over time. We should note that a negative biopsy significantly lowers the probability of subsequently identifying significant prostate cancer, specifically Gleason grade 2 or above. And that protective effect of a negative biopsy likely subsides over time. So if you've had a patient who had a negative biopsy 10 years ago, well, that protective effect from that negative biopsy is probably not the same as if they had a negative biopsy 6 months ago. Patients with a negative biopsy remain at risk for undetected or subsequently developing significant prostate cancer. And so that risk is 5 to 25% found in short-term interval rebiopsy. And the risk of prostate cancer mortality in these patients over 20 years still ranges between 1.4 and 5.2%. So big point here is that negative biopsy alone should not justify stopping prostate cancer screening. Our next guideline statement is that after a negative biopsy, clinicians should not solely use a PSA threshold to decide whether to repeat a biopsy. So we should still utilize PSA, and it should be utilized to calculate the risk of having prostate cancer, but using it solely as a deciding factor is often going to lead to repeated unnecessary biopsies, which is obviously something that we're trying to avoid, and it's going to lead to less accurate biopsies as well. So if we still have a concern of significant prostate cancer after a negative biopsy, we should be getting blood, urine, or tissue biomarkers, and we should be considering a high-quality MRI of the prostate if they have not had an MRI prior. We should not be utilizing, once again, PSA alone. Well, we had a very thorough discussion of the biomarkers, and we're going to talk about those in more detail, but it's debatable which biomarker alone or in combination is best. And like we talked about, in general, the tests are calibrated such that avoiding biopsy in the setting of a sub-threshold test reduces the biopsies by about a third and results in delayed detection or non-detection of a small percentage, 5 to 10% of clinically significant prostate cancers. And, you know, the guidelines go and make a point specifically, and I felt like this should be quoted exactly, is that given their general significant impact on biopsy reduction and their projected minimal impact on life expectancy, such tests, the biomarkers, may be of value among patients with modestly elevated PSAs, especially in patients with prior negative biopsy. What are the next few statements? Well, if the clinician and patient decide to continue screening after a negative biopsy, we should reevaluate the patient within the normal screening interval, which they describe as 2 to 4 years or sooner, depending on the risk of clinically significant prostate cancer and life expectancy. And at the time of reevaluation after negative biopsies, we should use a risk assessment tool that incorporates the protective effect of having a prior negative biopsy. So this is where we go back to shared decision-making, and we have to utilize the concept of shared decision-making even after a negative biopsy. So the first question is, should we resume prostate cancer screening? The second question should be, what's the time frame for follow-up? And based on the guidelines, it should mirror that of standard screening intervals. So at least within 2 to 4 years, and sometimes sooner, depending on the risk. I often do sooner, but at least 2 years. You should tell the patient that they shouldn't worry about an elevated PSA alone, as that should not trigger a rebiopsy, and that we should be utilizing biomarkers and MRI imaging if the PSA screening warrants. And then once again, utilizing risk assessment tools that incorporate the protective effects of a negative biopsy. Looking at the NCCN guidelines, they mirror that of the AUA guidelines. They say that we should strongly consider the biomarkers, regardless of whether an MRI was done, in situations where it can impact shared decision-making. We should consider an MRI if an MRI was not done, and this can allow for a more refined biopsy technique if there's a high suspicion of cancer. And then for atypia, they specifically say that we should consider repeat biopsy at 12 to 24 months. Quite honestly, in my practice, I've been utilizing the biomarkers quite readily for patients with atypia to make sure that we are following them correctly. Overall, the conclusions based on the guidelines are this: is number one, clinicians should communicate the biopsy findings, reassess the risk, and mutually decide with the patient on what the next steps are, whether it's adjunctive testing, stopping screening, or continuing standard screening. We shouldn't stop screening based solely off a negative PSA, and we shouldn't just do another biopsy based on a PSA alone. If screening is to continue, we should follow the standard rescreening intervals, and we should utilize risk assessment tools that incorporate the protective effects of a prior negative biopsy. And clinicians can consider biomarkers if it's going to impact shared decision-making. I think that from this point, we can go forward into our discussion in how to utilize these biomarkers in the post-biopsy setting. So starting off with our discussion, where does adjunctive testing fit in the guideline-directed approach for risk assessment after initial biopsy for you, Aaron, in your practice?
I think it's I mean, as you eloquently shared with us here, I mean, the biomarkers should be a part of it, as well as potentially MRI should be a part of it. I think it's kind of going to be evolving over the next few years. I think, a lot of patients we're seeing now that have had a negative biopsy may not have had any biomarkers, or maybe not had an MRI. So those are kind of easy. I think if they've not had an MRI or not had a biomarker and they had a negative biopsy, but there's still concern, then certainly that's kind of an easy thing. You follow the guidelines, you do a biomarker, you do an MRI, and then you're good to go. But I think as we incorporate more of these tools into our pathways, and patients have had a biomarker and have an MRI and then have a negative biopsy or have high-grade PIN or ASAP, then it's a little bit more challenging, I think, moving forward. As what do you repeat? Like if you had one biomarker and it was concerning and their biopsy is negative, do you do the same one? Maybe do a different one? Do another MRI? So I think that's going to present some challenges. But I think that one of the slides you had highlighted in capital letters, like a negative biopsy does not mean that they should stop being screened. And I think that's a key point, because a lot of patients, certainly if they didn't enjoy the biopsy process, if you say, oh, it was negative, you may never see them again, or they may just disappear. And then they're like, okay, I had my biopsy, I'm done. And certainly for a high-risk patient with family history or based on their ethnicity or other factors, you really have to explain to them, like, this is something we need to keep an eye on you and do this again. Because just because you had one negative biopsy, especially with a larger prostate, you're sampling a very small overall percentage of their prostate. So you just have to make sure they understand that. And then it's very easy with with doing 12 or 15 or even 18 core biopsy with MRI guidance, that it's still possible to miss cancer. So we need to keep an eye on them, and they can't just disappear, especially if they're in a high risk group.
Really great points. Jason, are you typically in patients who've had a prior biomarker utilizing the same biomarker if they've had a negative biopsy, or are you switching biomarkers?
No, I try to stay consistent. I think the key is, I try to stay consistent. I think if I'm going to do a repeat biopsy on a patient, I have to have a reason besides PSA. So it has to be a change in their MRI, or it has to be a change in their biomarker. PSA alone, especially in this population, is not a great predictor. And this population's big. I mean, if you look at Medicare data, 38% of patients will get a repeat biopsy within 5 years. So this is a significant population of patients, and I think you really have to have a reason to repeat a biopsy, a change in a biomarker or a change in your MRI scan.
Yeah, that's a great point. I think hopefully, again, over time as things evolve and people are educated, hopefully with programs like this of what we should be doing for biopsies. But I'm sure you've seen this with, some older people in your community. I mean, I've had patients who've had 5, 6, 7 biopsies where they would basically go and get one a year because their PSA was a little bit elevated and it goes up like 0.2, so they just do another biopsy again. I mean, it's a little crazy, some of the histories, but I guess, people, if you don't know any better, there's no better tests available. But hopefully now with the tools available, those kind of things will not happen anymore, because that certainly is not great, not good for the patients either.
Yeah, because I'm going back to our Pete's slides, that there's diminishing return on a repeat biopsy. You're getting after the second, third, fifth, sixth, that single digit numbers of actually finding cancer if they've been negative. What I find interesting though is if you use a pre-op MRI or pre-diagnosis MRI and follow the MRI, that you don't see, the detection of a significant cancer stays the same whether it's the second, third, fourth, or fifth, because you're biopsying based on the MRI. So I think that, like Aaron, that's a great point. We see it sometimes too, is, don't keep doing transrectal non-MRI based biopsies, because after multiple, you're really not helping these patients. Your detection rates get into the single digits.
Yeah, I think it's a really good point. What about in terms of patients who have, high grade PIN or ASAP? Are you still utilizing these biomarkers, because it's not technically a completely negative biopsy? And how does that change?
I think your point is valid. Those do help to decide, because ASAP and is there cancer or not cancer. But I think when you look at the trials that Hopkins did, I forgot who was the author, but they looked at all their atypia and ASAP, and of the ones when they did the repeat biopsy and really chased those down, most of those are low grade lesions. So most of those aren't high grade, clinically significant prostate cancer. So over the last few years, I really don't chase those a lot, because if you do find cancer, it's typically not clinically significant.
Yeah, I agree. I think that's 100%. Especially, I mean, just similar to the MRI findings, you could probably give the same biopsy to several different pathologists, and one would call ASAP, one would maybe not, one would find high grade PIN, and one would not. So I think with the tools we have available, I think those are more important really than some of those findings. Now, if there's multiple cores with ASAP, then certainly that's someone you want to keep a little closer eye on and really explain to them that maybe there is something there that we're missing. But other than that, I 100% agree. It's not someone we need to follow like every 3 months or something, super aggressive like that.
I would completely agree with that. And then finally, are any of you utilizing the risk assessment calculators that are out there? And do you have one that you favor?
I honestly don't. I don't know. The risk calculators are good. They perform better. There's nothing wrong with them. They're cheap. But I've just gone to pretty much biomarkers and MRIs.
Yeah, same. I mean, again, there's some good nomograms available. And most of them get on your phone or your MD Calc or one of those programs. So it's relevant, but it still requires multiple pieces of information to put in your calculation. If all of our EMRs or other technology would just spit these out automatically in the flow of a clinic visit, that'd be great. Maybe someday they'll do that. But to have to stop what you're doing and plug all that data in when you can have a biomarker, which we've reviewed has really good negative predictive values for most of them. I think that's as useful or more than most of these risk assessments. And as we talked about earlier, a lot of these biomarkers beat the PCPT risk calculator, which is a widely used nomogram for risk calculation. So if the biomarker is already better than that, then I don't think stopping to put all the data in there and get that number is really that helpful.
Yeah, I agree with you. I don't typically utilize the risk calculators, certainly from an operational perspective. When you're in a busy clinic, opening up a calculator and putting in all the data can slow you down. And there's something about getting an updated biomarker that just seems more present to what is going on with the patient currently, rather than utilizing a lot of the data that might be outdated that you plug into those calculators. Finally, one of the hard things to do and things that in conversations we have are with our patients with negative biopsies is when they need another biopsy, what kind of shared decision-making tools or tricks are you utilizing to get patients to understand that they need another biopsy after a negative biopsy?
This is where I found biomarkers very helpful because, as Aaron showed some of the results of what's printed for these patients, I just pull the sheet and show the patient. And most of the time, they'll give you a number of what's the likelihood of that patient having cancer. And, we know everybody's different. It's kind of like the analogy I use. It's like the weather. If there's a 30% chance of rain, I'm not bringing my umbrella, but my wife will bring an umbrella. But if a patient has some patients will freak out about 15%. Some will say, "Oh, I'm fine." So everybody has their own biases and their own personal beliefs, and using these biomarkers will give them that number so that they can decide themselves, well, I'll take that risk, or that's not going to keep me up at night. And it's what's fascinating, it's very different from patient to patient.
Yeah.
But that's where these biomarkers can really help you and help the patient make a decision with you.
Yeah, those are great points. It definitely varies patient to patient. Some people are very laissez-faire. Otherwise, some are, especially with significant family history or family members who've had significant cancer or died of cancer, like a father or uncle, for example, like they're going to be much more, aggressive in this in general. And I think part of this depends on what their initial biopsy was. Like if you had someone who had a standard 12-core biopsy, non-MRI guided, no biomarker previously, that now is their PSA has been increasing. Like that's a much easier discussion to have if you have now an MRI and or a biomarker to say, hey, this new data is concerning. Like there's something we may have missed, or whoever did the biopsy may have missed. I think the more challenging thing, as we touched on before, is these patients now who've had an MRI guided biopsy, who've had a biomarker previously, and now something's changed. Their PSA's gone up. Their ISO-PSA index has gone up, some other factors gone up that's more concerning. Now it's really trying to convince them based on the data that's available that hey, you do need do another biopsy. Maybe as Jason said, you do a different technique. Maybe you do a transperineal if you're worried about something anterior or something along those lines. But it is a little bit more difficult conversation if they've kind of had an updated workup before, and then you need to do another one. But again, it's if you explain to them we're trying to find the bad cancers, something is pointing that this is a potentially more aggressive cancer that could affect you. Most people can be convinced, but certainly there's those that just don't want any part of a repeat biopsy. So I guess that's our job to try to make the first one a reasonably decent experience, so they're not really traumatized about having a second one if they need it.
This has been an excellent discussion on the recent advances in prostate cancer screening, particularly the new biomarker tests that enhance diagnostic accuracy, reduce unnecessary biopsies, and improve risk assessment and decision-making. I want to extend my gratitude to my colleagues, Dr. Arpit Shah, and Dr. Aaron Berger for their valuable contributions to this educational activity. We hope the information we've shared will be beneficial as you continue to provide exceptional care to your patients. Thank you so much for listening today.
Dr. Michael Cohen highlights the significant limitations of traditional methods for managing female incontinence. They include absorbent pads and catheters, which often lead to discomfort, skin irritation, and a higher risk of infections. These solutions fail to offer a dignified and effective long-term option for women. The Yori Cap female design addresses these challenges by conforming to the female anatomy, creating a secure seal that prevents leaks and protects the urethra from contaminants. This innovation is poised to make a substantial impact in clinical, long-term care, and home settings. Learn more next week at uronurse.com.
Hey, welcome back. So I think that was really a great presentation. That was a long one, I understand, but it's I think it was worth the time. Hey, be sure to get your CEs for it. So those will be coming up shortly as soon as I go off the show. And join us next week for that discussion. I talked to Dr. Cohen over at the SUNA meeting when I was there a couple weeks ago, and they've got some new indications for Yori Cap, some new follow-up information. So I think it's going to be a great discussion. So join us next week for that. And the rest of the day, enjoy your day. Thanks for hanging in there.